Hello and welcome to a Quanterion Solutions webinar that will provide an overview of lessons learned from the COVID-19 pandemic. My name is Steve Redifer and I'm the Director of National Capital Region Operations for Quanterion, and we have the privilege of hosting Dr. Mark Jarrett for today's presentation. I'm grateful to all of you who helped us to spread the word about this event, as well as taking time out to join us for this important topic. I'd like to begin by thanking our sponsor, Quanterion Solutions Incorporated, without whose support this webinar would not be possible. Quanterion Solutions is a New York-based small business with offices in the National Capital Region, Albuquerque, New Mexico, Colorado, Florida, and North Carolina. Quanterion specializes in providing high-quality analytical services, products, and training across a number of technical disciplines, including cybersecurity, software design and development, knowledge management, critical infrastructure protection, cyber and defense, homeland security, material science, as well as reliability, maintainability, and quality. You can find more information at www.quanterion.com. So I've got a few housekeeping notes as we begin today. Please note that all the lines have been muted. So if you have questions during the webinar, submit them using the attendee chat box on the left-hand side of the screen. We're going to work to save the last 10 minutes or so of this presentation to go over those questions and discuss them. If for some reason we should run out of time or there are more questions than we can respond to, we will make note of all remaining questions and post responses after the conclusion of the brief. Please also note that this webinar is being recorded. A link for the recording as well as the slides will be available at www.quanterion.com for later download. With that, it is my pleasure to introduce to you today's presenter, Dr. Mark Jarrett. Dr. Jarrett serves as the Chief Quality Officer and Deputy Chief Medical Officer for Northwell Health in Metro New York City. Northwell Health is a nonprofit integrated healthcare network that is New York State's largest healthcare provider and private employer with more than 72,000 employees, over 800 hospitals and care centers, and 3,300 physicians. Dr. Jarrett is also a professor of medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, part of the Northwell Health organization. Prior to joining Northwell, Dr. Jarrett served as Chief Medical Officer, Director of Graduate Medical Education, and Emergency Preparedness Coordinator at Staten Island University Hospital. Dr. Jarrett has extensive research experience and has been published on the subject of immune response in systemic lupus erythematosus, quality in healthcare, as well as cybersecurity in healthcare. Dr. Jarrett is board certified in internal medicine and rheumatology, a fellow of the American College of Physicians and the American College of Rheumatology, and past president of the Richmond County Medical Society. He earned his medical degree from New York University School of Medicine and holds a Master of Business Administration from Wagner College and a Master of Science in Medical Informatics from Northwestern University. It is our distinct pleasure and honor to host Dr. Jarrett today. With that, the floor is yours, Mark.
Thank you very much. Good afternoon to some of you. Good morning to others. And I don't know, maybe somebody's listening from overseas, so maybe good evening. What I'm going to try and do is go over some of the issues that we dealt with at Northwell with the COVID pandemic. As you know, New York was the epicenter. Now we have other epicenters in the United States. And what I've done in my slides actually is pulled some of my old slides from the very beginning of this because I'd like to give you a flavor in some ways of what we were working with in terms of knowledge at the beginning because we were making decisions on the fly as we went. I'm going to try and do that as well as look at where we are now in our recovery stage and also some of the things we're thinking about in terms of resurgence. So we're going to try and cover all those things today. So let me go to the first slide. So as said, Northwell Health is a very large integrated healthcare system. We truly are integrated, and we'll discuss that, what the advantage of that was during the worst parts of New York outbreak. We're 23 acute care hospitals, including a full-time children's hospital, 2 psychiatric hospitals, behavioral health hospitals. We have over 800 ambulatory sites. We have 2 skilled nursing facilities, which obviously produces other problems, as you've seen in the news in terms of New York. We have full gamut of post-acute care services, and as stated, we have about 72,000 employees. And actually, we have about 3,800 full-time faculty, and about 1,200 voluntary or private physicians who work with us. So let me just paint a picture first of how this started. So our first admission to any of our Northwell hospitals was back on March 7th. It is clear now that there was disease out there prior to that, and back in even January, probably in the New York area, and that reflects the global nature of New York. And just like Washington State is a big area for people coming over from Asia and China especially, so is New York City. And we think that that is why we were probably seeing the disease circulating even before the majority of the disease came from Europe. So our first admission was back in the beginning of March. Our first patient that expired was March 12th. That's where we started. By April 18th, so we're really talking about 6 weeks really, we had, as inpatients in our health system, already 3,500 COVID patients. These are the ones who required admission. And over 800 of those were already on ventilators because they were extremely ill. We wound up, and as I'll talk about later, having to increase our capacity. Our hospitals became 95% COVID hospitals, and we'll go into our census and things like that in a few moments. When we look at our mortality since the beginning of March through June, we have had over 3,500 COVID deaths in our hospitals. That doesn't count people who passed away at home, people who maybe went to a long-term care facility and passed away. And these were only admitted patients, not even patients who came to the ED and before they even got admitted were in such extremis that they passed away. And to put that in perspective, we review every single mortality in our health system centrally through my quality department for quality purposes. And normally we review about 500 a month. So in the process of approximately 3 months, it would be 1,500 total mortalities. That includes heart disease, surgery, you name it, people who were not on hospice but died of cancer. So this 3,500 number is quite staggering. In addition, through the month of July so far, if we go back, we've had over 20,000 patients admitted with COVID. We actually represented about 35, 40%, 30% of all the COVID admissions in the greater New York metropolitan area. Our hospitals range, for those of you who know New York, not only from Manhattan and 3 of the other boroughs. We don't have any hospitals in the Bronx. We also have Westchester, and then we go all the way out on Long Island to the bifurcation of the Two Forks out to Riverhead. So we have a large footprint, and we had unfortunately, lots of patients during this period of time. I'm just looking for my mouse, which disappeared. There it is on me. Okay. So, as I said, I'm going to talk about through the 3 stages, which really applies to all COVID outbreaks: acute crisis, recovery, and then plans for resurgence. And just a little background, I know you all know this, but to remind you, COVID can present very mildly with common symptoms, and a lot of the things that we normally test for, such as the coronavirus, other coronaviruses which do occur at this time, in the spring sometimes. Obviously, our lab tests did not test for that. All right, and you all know a lot about coronavirus, and I'm not going to go into detail. We were all hopeful that this would be like SARS, which came up and went away very, very quickly. It didn't. As you know, the Middle East respiratory syndrome has been percolating out in the Middle East, but it's really not spread much to the rest of the world unless a patient came here. Seems to be very little transmission person to person. It's mostly camel to person. But COVID-19 was very different in the fact that it was transmitted person to person. So let me talk a little bit about transmission, because this truly was a lesson learned. And actually, the result of this and some decisions we made early, which now everybody's kind of followed, made us very proud of what we did. So initially, nobody was sure, according to China, whether this spread to person to person? It obviously became very clear it does. Okay, so that's number one. Number two is there are two types of transmission. There's airborne, there's airborne, and then there's droplet infections. And we all felt that this was probably mostly droplets, and therefore when you sneeze, the virus was on the droplets, or you coughed, and eventually those droplets dropped to the ground. And that is, in theory, why we think during the summer, flu and other things which are spread by droplets actually go away because the humidity weighs down those droplets a little bit more, so to speak, and they fall faster to the ground. This is important because of the fact that if it's airborne, then, for example, procedure or surgical masks don't work as well as N95 masks. You need N95 respirators. Also, if things are airborne, they spread just by loud talking. So for those of us who were born in Brooklyn, like myself, it's more of a problem. And also, they hang around a lot longer in the air because they're not attached to droplets. So up until recently, we've all been under the assumption that it's really due to droplets and probably not very much from airborne. There's a lot of evidence now that airborne also plays a role. However, that being said, it is not the main route of transmission. Why do I feel that? I can't prove that, but why do I feel that? Well, very early on, when this started to really percolate in our hospitals, we had to make a decision about masking our staff. Clearly, anybody who worked in the emergency room or anybody who worked on a COVID unit or an area that we were isolating people because we thought they might have COVID, those areas we asked the staff to wear PPE, including wearing an N95 respirator, which is either like the mask that looks like what the people use in construction, or what we call a duckbill mask, and those you have to be fit tested for. So to make sure that you're really wearing them properly, different sizes are needed because of different size faces. If you have a beard, you got to get rid of the beard. Obviously, we put that there. But then we very quickly came to a decision that even patients that we didn't think had COVID, if they can tolerate it, we would put a mask on them immediately. So if they came into the emergency room or they were up on the floors. In addition, we put a surgical mask, that same type of mask, a procedure mask, not an N95, on all of our staff who was not working in those two areas I just mentioned where we know COVID patients would either present or be hospitalized. We think, now those don't really work great with airborne transmission, but they do help, especially if you have 6 feet of social distancing and both of you are wearing the mask. Where this was an advantage and why we think it was an advantage is now fast forward now to last month, about 4 weeks ago, 5 weeks ago, when we did antibody testing on our employees, the frontline employees. And we have about 45,000 employees who are really frontline, and we tested almost all of them voluntarily for antibodies. And what we found was our antibody positivity rate matched the community rate, and we didn't look at the community rate where the hospital was. We looked at the community rate where they lived, and that was important because some of our hospitals in relatively rural areas or very suburban areas, and people drive there. But then we have hospitals like in Queens, where was one of the two which was probably the biggest hotspot in New York metropolitan area, and there people take public transportation as well as live in communities with high incidence or high prevalence. So we try to balance all those factors, and when we look back at it, what we came to the conclusion is that our rates of positivity in our staff, the frontline staff, was really no higher and in some cases lower than the community. And that gave us the feeling that putting on those procedure masks, the surgical masks, I'll use the word surgical mask now because it's just what everybody pictures, but they're really what formerly procedure masks, that actually it provided protection, because certainly in the beginning, we had patients who had COVID that we didn't know it because there was no real testing available in a reasonable amount of time. So This justifies the concept, to me, of why we all should be wearing masks and why it's important. And that I know all the issues going on, and I don't want to talk about the politics of it, and also the issues of people saying, I don't want somebody telling me what to do. But the reality is we feel this made a big difference, and our rate of our staff coming down with COVID was not as bad as we thought it might be. In fact, was better. So I think that that's a very positive lesson learned, that, having everybody, and the same thing goes now for employers, people in factories, is really important, as well as, walking out on the street. Now, as I said, there were a lot of unknowns in March and April, and the rules were constantly changing. And we had a lot of different rules. So we might in New York State, we might have the CDC coming out with one set of standards about how long people have to be out if they have the disease, etc. We had the State Department of Health that didn't match the CDC. And then finally, for example, in New York City, which has a great Department of Health, probably the best public Department of Health in the country, they give a third set of rules. This made it very, very difficult for us. And what we decided to do in the end is look at all three sets of rules and make a decision that what we thought was clinically best. And I'll refer back to this probably again a little later, but one of the keys to that was we put together a clinical advisory group. It had infection prevention nurses, head of a nursing, from infection prevention, we had our chief of infectious disease, we had our emergency room, we had other experts on this group, not too large. We had a larger group, but then there was a small core group that met almost every single day, if not every day, virtually. And this group looked at the things and made a decision. This is the guidance we're going to follow, because A, it meant the safest things for our staff, because you have to protect your staff. And number two, we made the decision, this will work, because some things were so out in left field in the beginning that we would have no staff very, very quickly. So this became a big issue. The issue of how long people are infectious was very contentious, and it still is. The CDC just changed their guidelines again this past Friday. Okay, we didn't know what the mortality rate was going to be. Was this going to go away when the weather warmed up or not? We didn't know. There was some question in the beginning about fecal and oral route of spread. Certainly what we call fomites, people touching something and you touching it, made a difference in places like the subways or buses. Made probably less of a difference in the hospital because people wear gloves, they were constantly washing their hands. Probably the most important lesson is if you touch something, just don't touch your eyes or your nose or your mouth. And the second you tell that to somebody, they touch their eyes, their nose, or their mouth. So you have to be very cautious with that as well, but you really need to let them know that. The other biggest question we didn't know was how the spread occurred. Was there an asymptomatic spread or not an asymptomatic spread? Now we know in retrospect, especially young people can be asymptomatic and spread the disease, as well as people who are going to develop symptoms even 24 or 36 hours before they may be infectious. Also to realize, even though asymptomatic people spread the disease, it doesn't have to be young people. There were elderly people who, when we test them, for example, even at a nursing home or an employee who's older, and we did a diagnostic test, lo and behold, they were positive, yet at the same time they had absolutely no symptoms. So we have to also be cautious that, it's not always age-based. It appears now that children under 10 are less shedders than anybody over 10. That doesn't mean they don't shed the virus, but there's something unique about the 0 to 10 age group that seems to protect them, except for this still rare but polyinflammatory syndrome that occurred in children. Most of it is really not, it's still a rare event, and therefore children under 10 seem to get away with this. What does this mean for opening schools? We really don't know. Because, children under 10 don't like to wear masks. And teachers, are going to be older. And we don't know, even if the shedding is low, we don't know what it really means. And I happened to have a conversation with somebody in New York about teachers, and they made the comment, only teachers are being asked to congregate back in rooms with people where we're making everybody else socially distance. So there are unique things that we got to worry about with children. This is an old slide from what we did about preparedness, but I will point out certain things again, because again, I left this up there to show where we were back in the February, March area. When this got reported out in January, the emergency management people and some of our clinical leaders, including myself, started meeting about this. We started putting things, just like we did with Ebola, you come into the emergency room, did you travel to China, especially Wuhan, things like that. It became obvious, however, that we really needed a formal emergency operating center, and we went to a HICS level 2 back in the beginning of February, and soon migrated on to a major, opened up our whole emergency operations center, and we're meeting daily. Now a lesson learned, which I think people now would be rather obvious. We started meeting in the beginning of March, and we had like 80 people in this large conference room all meeting. Typical formal emergency management EOC with everybody from the clinical group to planning, logistics to finance. And then 2 of our clinical chairs came down from living in 2 different areas and got community spread, came down with COVID, which meant that basically 3/4 of the emergency operating center teams, including myself, had to be quarantined because we didn't know for 2 weeks if we got exposed. And actually a few more did get exposed. We started meeting remotely after that, and obviously, like everybody else, we've been remotely meeting about everything since that period of time. But don't congregate your staff, your emergency staff, or any senior staff together. Let them keep working remotely. Now that prevalence is low, we will meet in a large room with 6 or 10 of us together, spread out in the room, and everybody's wearing masks. So that's important. We quickly moved to remote working for any employees that could, and actually out of 72,000 employees, remember, we're a hands-on industry where you got to take care of patients, but despite that, we have about 14,000 employees who are working remotely from home who never did that before. So that is something else that we learned to do early on, is get that remotely going. I put this slide up again as an older slide to remind everybody, and it's still a problem, testing. And let me just divert for a second on the testing issue. So there are 2 types of tests. There's the PCR test, which is a diagnostic test, and there's the antibody test, which tells you had the disease at some time in the past, the IgG antibody test. So the PCR test right now, the best way to do it is a nasal swab that goes all the way into the back of your nasopharynx. We always keenly call it the brain biopsy swab. And, that test in the right hands is very sensitive and very specific. Okay, so it picks up almost all the patients, and it really does not show if you have, another disease come back positive. There are some forms of rapid testing with the nasal swab that can give you answers instead of, longer period of time in 3 hours. There are several problems. Number one, when there's a high prevalence of the disease, it has a high false negative result. So if you get a negative result, you still have to run the PCR test, which can take 12 hours if you're lucky. If, however, in a low prevalence state, like right now in New York, where there's very little disease, just because of the way statistics work, it actually doesn't have many false negatives, and it can be helpful. The big problem with the rapid test is almost none of it available in the country. Supplies are extremely limited. For our whole large health system, maybe every day we have a supply of maybe 300 that we could do total, or 400 we could do total. That is not very good. In terms of PCR testing, we have a very large central lab. Our central lab actually is 200 yards long in length, very automated lab. We can now run about 7,000 or 8,000 PCR tests per day in a 24-hour period, and we hope to have the ability to run, by the end of September, 16,000. And as I get to Resurgence, I'll point out sounds like a lot, it's not a heck of a lot. All the commercial labs can now run PCRs, and they have the ability to run, 100,000 a day or 150,000 a day, and Quest and LabCorp. That sounded like a lot until Florida and Texas and everybody else now had, surges of this disease and are trying to test lots of people. And I heard an anecdotal story from University of Texas Children's Hospital that kids are waiting for tests to come back for anywhere from 1 to 3 weeks. Well, that does you no good if you need to know if somebody needs to be admitted to a COVID unit, a non-COVID unit, what's going on. So testing still remains a problem because of volume, and if we see a resurgence in the fall across the country, we will need even more massive testing than we have now. The second test that we have is an antibody test, and that's for IgG. In our hands, our antibody test is about 95% sensitive. So about 5% of people who tested positive by PCR and now had an antibody test done will turn positive antibody. There are different companies that make it. Others may have 96%, but none is 100%. The advantage of doing the antibody testing is it lets you evaluate, like we did our employees, whether our protection worked. It lets you look for prevalence in a community. If there's a hot spot, all of a sudden you see more admissions coming from that area or more PCR test positive. You confirm it, seeing if, you can test for how much the community has had. Where we hope to go in the future is saying if we know you had a positive PCR in the past and you have a positive IgG antibody, we don't think you're going to get the disease again. That's not 100% proven yet, and that's why we can't say that yet. But that's where we hope we're going, because if we could go there, then it will also clear up, which the CDC is finally starting to do. Those people who had a positive PCR were sick, got all better, and 6 weeks later somebody does another PCR on them, and it's positive again. The reason it's probably positive is not active infection, because what it's measuring is viral particles and remnants of messenger RNA, and that can persist in the nose for a long period of time, even though you have no active virus anymore. So, that's the testing that we do. And, doing a PCR is great for today, but you can be sick. If you're asymptomatic and you do a PCR on me today, 48 hours later, I can start having symptoms and come down with the disease. It does not predict. It just tells you at that point of time, that moment, you did not have the disease. Where we are using that now is in our recovery. So we make patients get a PCR test, hopefully within 48, sometimes up to 72 hours, depending on the type of procedure, beforehand, for two reasons. One, it tells us the patient's unlikely, not 100%, because unless you did it 12 or 24 hours before, that would give you more confidence, but it's very hard to operationalize. It would tell you, number one, you wouldn't get COVID following your surgery, which provides two things. One, it means if you have to be recovered in a common area, it's likely you're not going to spread anything to any other patients who are COVID negative. And number two is, if there's literature coming out, if you get COVID in the post-operative period, 2-3 days later, you actually have a worse outcome than if you didn't get COVID. You're much more at risk probably because of the pulmonary issues, anesthesia, etc. So that's a good example where to use PCR testing. Using PCR testing to look at prevalence in a community is not as good as looking at antibodies, because antibodies, even if it's 95%, still gives you an idea how many have had the disease and how much immunity potentially might be in the community. Doesn't mean it's 100%, but it's there. So a lot of what we've done is try to balance those two tests to use them to help us figure out what we should do with individual patients and also our employees. So that's another lesson learned, to learn how to balance it. The lesson learned is make sure if you're a hospital, you have enough testing materials. If you're not a hospital, you're a business, make sure you have access to labs which can run high volumes of these things, because you start testing either PCR or antibodies, it's a lot of patients, okay? Now, not every patient right now needs a PCR result back instantly. If somebody comes into an outpatient office, 30 years old, not that sick, no risk factors, clearly probably has COVID, they've lost their taste or lost their sense of smell, and they're not sick, you're not going to admit them to the hospital. You can get the results back in 2 days, 3 days. It's probably not critical. If you need to be admitted to the hospital, we want to make sure that you're isolated in the right unit. And even if you're staying as an outpatient, there are now trials going on looking at certain treatments for ambulatory patients, those who are at risk. So let's say a 70-year-old who's got hypertension and heart disease or diabetes. And people are looking at using antiviral drugs like remdesivir as an outpatient, because that may actually prevent them from getting much sicker. So we may need, that's why I said before, our capacity for testing needs to go up dramatically in the future, because we may now have a large population of patients that we have to decide about using a potentially dangerous medication that has side effects, and a medication that's very expensive, and go through the nuisance of administering it intravenously as an outpatient on patients who really need it, and you're going to need those results sooner rather than later. It's like Tamiflu for the flu. You want to take it within 24 hours of you getting sick. Probably will be the same for remdesivir if we use it as an outpatient drug. Okay? Whoops. Go back one. I think it's a little lag. So let me go up one again. All right. This again goes into the fact that we followed up our EOC. One of the other things that we did was critical, was we developed algorithms, and the clinical group did this working with the operational people. Algorithms for how we're going to test people and how we're going to treat people. We have 23 hospitals, which means that we had at least 50 opinions how to do everything, probably multiplied by the number of doctors. And there was no hard science in this. And every week there was another article saying this drug worked or this drug didn't work. And I'm not getting again into the politics of it. This is why we need randomized controlled studies. And it is very difficult when somebody is dying to say, well, we're going to put you in the placebo group versus the treatment group. But recognize some of the treatments we gave, especially some of the anti-interleukin drugs and things like that, might have potentially caused more deaths than less deaths. So we need those treatment algorithms. Also, treatment of patients with severe pulmonary problems like acute respiratory distress syndrome benefit sometimes from things we call proning, where we actually, even before the patient's put on a respirator, we turn them over. They get actually better oxygenation. They're on their face. But that's a technique that a lot of hospitals don't do very often. So again, we had to do that in just-in-time training. So we developed protocols, and we did all those things as well. And that was very critical to keeping this, keeping things a little bit safer for the patients. Looking for my mouse again. Hold on, it's got to be right here somewhere. Sometimes it fades out from the thing. There we go. Okay, I'm sorry. All right. PPE, it becomes very important to track how much you're using. You also have the issue, if you're a union facility, of dealing with the unions with it, which was a little hard, but we educated a lot. But you really need to make sure you know what PPE to use, how to use it, and watch the stockpiles. We were lucky. Northwell has a long history of emergency management with a lot of stockpiles. I mean, recognize we're in New York, so we lived, with the first World Trade Center bombing. We lived the second one. We've had, Superstorm Sandy. We actually were, one of our hospitals was actually the epicenter of H1N1 years ago. So we've had all those things happen. We have a huge, robust emergency medicine. So we were lucky. Other hospitals in New York were not as lucky. And, although the government did eventually send things, you really need to prepare, not thinking that the government's going to give you everything. Number two is beds. We normally have on the medical surgical side, I would say 3,500 to 4,000 beds. Because of this, we actually raised our bed count to by 1,500 or 1,600 beds. We tore apart an auditorium that actually is one of those slant auditoriums called 500 people, and we leveled the floor and built room for patients there. One of the things I will say about bed capacity, if it's got to be increased, is critically build it on your campus, because the next issue is staffing. If you build it somewhere else, you have to duplicate everything, and that becomes very difficult. In New York, they opened the Jacob Javits Center, the convention center, as well as they brought in the hospital ship. I'll just say having the USS Comfort here was helpful. However, the reality was it's designed for young people with mass trauma. Okay, that's why it's a military hospital ship. So it's got bunk beds in it. It's designed for people who, except in the ICU areas, who can get up and walk to the bathroom. Not really designed well for elderly people who are very, very ill. Jacob Javits worked out well because that was a great place to offload patients who are clinically doing better, did not need to be on a respirator or anything, but were not ready to go home. And that was a great resource for doing that. But the patients who need acute care, try and keep them on your campus. Because the next issue that comes up is, what are you going to do about staffing? We actually got some extra nurses, not only from agencies, but from Intermountain Health and one or two other health systems. And currently we're about to send some of our nurse teams and doctor teams out to Texas and to Florida and back out to Intermountain in Utah to help them. Staffing becomes a problem. Half of your hospital becomes an ICU. You do not have enough intensivists. We repurposed anesthesiologists to be intensivists, and that was a great thing. And then we used a buddy system. So let's say we don't have enough intensivists to cover every patient the way we would like. We would buddy up an intensivist, let's say, with 2-3 hospitalists, and therefore the hospitals would be practicing kind of critical care medicine, but they had an intensivist there also. We also used our electronic EICU and telemedicine to help support them. We did the same thing with the nurses. You didn't have enough critical care nurses to go around, so what we did was we buddy up 2-3 regular floor nurses, med-surg nurses, with a critical care nurse, so the critical care nurse had a bigger span of control, but actually had people who could do things to help them. So those were things that we also did in order to spread the wealth with the staff. But if I first had to send staff out to a facility that was somewhere else, besides the transportation issues, then that becomes a problem, because then you're losing staff in your main centers where you need it, you have your sickest patients. Also, a very critical issue here is predicting how many beds you need, and all of this requires a lot of informatics and data. So what we did was we developed predictive models based on our admissions, our discharges, and our mortalities to figure out when we would have to build more capacity and where we were on the capacity end. And I can't emphasize enough, you need a lot of informatics to give you good data. So let me move on now. That's kind of what went on. I'm going to move this with a lot of communication also. So, we've developed, all these regional surge plans. We evaluated everything. So now we're in recovery. So one of the first things we had to do was get back to urgent and elective surgeries, chemotherapies, and I talked about the testing we did with it. And if afterwards anybody wants some more particulars, offline, you can email me and let me know. Surveillance, that is the big issue right now. We are very concerned in New York because, first of all, we have a lot of our staff, both physicians and nurses and others, taking their kids to college somewhere else. And now they're going to states that are they got to be quarantined when they come back. So that's an issue. We're also still in New York, and we get a lot of flights in, and we're worried about spread. We're also worried about all our young people who are partying and not wearing masks. All right. We developed what we call not COVID-free areas, but COVID-contained areas where there is, so in a hospital, we may have one area where we have COVID far away from our organ transplant area, and it is a very restricted area. One of our problems in COVID has been convincing the public it's safe to come back to a hospital. In New York, the mortality of people being pronounced at home by the emergency medical services, by the EMTs, was double of normal, because people with heart attacks and strokes decided not to come in the hospital because they were afraid, and they died at home, which is terrible. The last aspect I'll talk about in recovery and then go into resurgence for a few minutes is supportive staff. This is everybody. This was a horrific event. Our staff talked about, who are pretty hardened people, talked about, walking onto whole units where there are 40 patients, all sedated, all with a Christmas tree of infusion things going into them, and on respirators. And they ranged anywhere from the 20s up to the 90s. They also were involved with the fact that we did not allow visitors. So we had many situations where, even though we gave the patients iPads, sometimes they didn't know how to use it, maybe an older patient, we'd literally have patients FaceTiming with their families saying goodbye because they were getting intubated and they knew that there was a good chance they would never wake up. For the staff to help do that was just horrible. So we did a lot of things during the event, including, events where, for example, when we had, somebody who had been very sick and finally made it out, the whole staff came out and clapped. The communities were great. 7 o'clock every night outside many of our hospitals, like in the city where there were apartment houses, people were clapping and banging pans outside the windows at the change of shift. At our more suburban rural hospitals, we had the police departments and fire departments every night lining up and clapping. So there was a lot of support. But we look at it that this is a long-term traumatic event. And I'll give the analogy, it's like being in Iraq, in the early days with all the the IEDs and everything. This was day after day after day. 9/11 was a single event. Yes, it had a lot of trauma and PTSD, but it was a single event. Mass casualty events usually are very defined. This went on for week after week after week with staff working more hours than they ever did before. So we've done a lot of behavioral health things, working with our staff, trying to keep them on an even keel. And I'll finalize this now with Resurgence, which obviously doesn't apply to some of the areas in the country which are back where we were in March and April. We're using a lot of surveillance and predictive modeling, again, trying to figure out, based on what went on in the past, what we'll need when, what are our triggers when we have to worry about a resurgence. We're clearly worried about the flu next, in the fall, because that's going to complicate matters much more. And clearly, people don't want to take the vaccines. You don't get, and the vaccines don't always work well. The only good thing about the flu is if we get everybody to wear masks, there'll be a heck of a lot less flu transmission because we're preventing droplet infection. We've developed a lot of new dashboards that are both operational and clinical to help guide us if there's a resurgence. Working very hard to build up our testing capacity. We're looking at all of our past history of what went on so that we can look and see what clinical guidelines should be changed, looking at the literature from what other people have learned, but being very critical. But we're updating our clinical guidelines constantly. Things have quieted down. We went from 3,500 patients in the hospital. Now we have 99 with COVID. But part of that is that we have to keep giving training back to our staff. So the staff, like the hospitalists who are doing, managing respirators and things like that, are being retrained so that they're up to date and they don't lose all the skill sets they developed. And the final thing I'll bring up is we brought in an outside firm in addition to our own people to look at the environmental factors. When we're bringing people back, people for procedures, what can we do about social distancing in the office? What can we do about shielding with plexiglass, etc.? And most importantly, we're looking at what we're doing with air exchanges, what we're doing with HEPA filters. All of those things are being looked at, and many of them have been addressed already in the hospital. We've turned rooms by using a HEPA filter and an exhaust that goes into a hole we cut into the glass of a room, and we turned a lot of rooms into negative pressure rooms. We're doing that more. So we're doing a lot of these environmental factors. We have not given up any of the spaces that we made for our surge capacity, because even though we didn't use all of them, we still feel that rather than taking them down and then putting them up 3 months later, we're keeping them in place, including couple of huge medical tents we have, that we're keeping them in place because it's much easier to keep them in place and just maintain them, to have to go through the bother of doing that, or we resurrect an auditorium and have to tear it down again. And quite frankly, we're not having people go into a major auditorium anyway, so that's going to stay through the fall into the winter. So I'm going to stop at that at this point. I know I talk quickly. I am from Brooklyn, and I will take any questions that came up on the chat that Steve or the others feel that we should be answering.
Hey, Mark, thank you very much for taking the time out today to prepare that and give it. Very, very informative. And we got a number of questions. And so for everybody, we have about 12 minutes remaining. Mark has a hard stop, and we don't want to keep people longer than the hour we promised. So I'll get through as many of these as we can in the time we have remaining. So, Mark, one of the first questions that was asked was, how accurate do you think the antibody tests are?
In our hands, we use the Abbott right now, not the Rapid, but the regular Abbott. I think it's the Ortho Abbott or whatever. There's so many new tests, I became like a lab person. We tested it against serum that we had saved from our blood bank from early 2019, so before there was any question that there was no COVID in the community. We find it's 95% sensitive, which means we missed 5 out of 100 who truly had COVID, because we tested on our employees where they had a positive PCR and they were symptomatic. And the specificity is about 99%, which means probably 1 out of 100 may be a false positive, but over 99 out of 100 are truly specific. So we think in our hands it's very good. In most of the commercial labs, it's the same way. There are different tests that may be looking for different IgGs. That's the problem. And it's not just having an IgG. You need to have a neutralizing an antibody that actually neutralizes the virus. And that's not purely by antibodies. That's also involving your T cells from the immune system. And that's why when we heard from the University of Oxford, their vaccine that they're working on seems to have an effect both on IgG and T cells. That's a very promising thing, because it's the T cells which may give us more longer lasting immunity.
Yeah, thank you for that, Mark. And you kind of hit on the false positives, which was a question that Gretchen had asked about, was the false positives. So there was a question from Nicholas. He quotes an article that he believes he read in the New England Journal of Medicine talking about universal masking in hospitals. And he quotes reflexive reaction to anxiety over the pandemic. And then they talk about, the pluses and minuses of masks, because people may touch their face more often to adjust the mask. Do you believe there's any validity in that? What do you think the pros and cons are of mask wearing?
I think first of all, do not downplay anxiety. All right. People who work in a hospital come in there every day risking their lives, literally, in this situation. So if we can do anything that reduces their anxiety, I don't think there's anything wrong with that. That's number one. Number two is, I think based on our study of what we did with our employees and antibodies, we feel, in fact, we're publishing it. It's hopefully going to be out, be accepted by JAMA in the next few days. We feel very comfortably that universally masking all of our patients during the outbreak was critical in keeping them healthy, because of the fact that you do not always know, especially when the disease is really out there. You don't know who's got COVID and who doesn't. We're now testing every single patient that's admitted for COVID. They come in with a fractured hip, they're still getting tested. In a low prevalence state like we have in New York today, we get very few positives, but we do get some. And that one positive in an asymptomatic person who came in for a fracture could spread it to a lot of staff if the staff is not wearing a mask. So we feel very strongly it is important. And now that the evidence is coming out more about, airborne as well as droplet, we think it even makes more sense since airborne, even though the mask doesn't stop all really as effectively as an N95, the airborne, it does stop it somewhat. And that may make the difference. That plus the distancing may make the difference between people getting sick and not getting sick. Because we know we had lots of patients who turned out a week later to be COVID positive because we didn't have testing, and yet the staff on that floor did not get sick. And the reason we think they didn't get sick is because we universally masked them right from the beginning.
So thank you for that, Mark. I think you covered a number of questions that we had just with that one response. There's another interesting thing that's come up in two different questions that was actually new to me, talking about glutathione, specifically Ezra quotes research paper in the American Chemical Society talking about a deficiency of glutathione may be a cause of morbidity in COVID-19 patients. And then there's questions about whether or not plussing up the glutathione would be useful in the treatment of patients. Do you all have any experience with that or any thoughts on that?
I read an article about it or saw a reference to the article. I didn't read the original article. I think, it's a two-edged sword. One, we have a lot of things coming out. We don't know what they mean or they don't mean. And a lot of people base things on a study of 50 people or observational studies. The only way we're going to know this stuff is randomized controlled studies. It is the only way. And it's a hard thing to do, but we got to do it. But I'll take the counterpoint and say, if we look back at HIV and how long it took to get treatment and how long it got before we understood things, and now recognize that here in the United States we've had this disease since, let's say, late January, beginning of February, and this is only July, and look how much literature there is out there, look how much experience there is out there, look how much research has been done already. I think that's the positive everybody forgets. If you went back, look how long it took, John Salk to develop a polio vaccine, all right? And that certainly was an urgent problem because, it was horrific in its effect. Yet, look how long it took them to develop that vaccine. And here we're talking about we may have something by the end of the year, the beginning of next, or several vaccines. Hopefully they'll be effective. But so there's lots of articles out there, and I don't always know what they mean, and I don't think we should treat every patient based on every article. However, I think these are avenues of research which should not be discounted and need to be should be still be applauded rather than worried about. But we just got to look at it and not go on the bandwagon that, this is the new thing that's out, we should treat everybody, or immediately do X, Y, or Z or give this supplement because we don't know what it means. It may affect one part of the equation but make things worse for the other part of the equation. And the example I give is the anti-leukin antibodies, which I think if given early, the anti-leukin drugs, like IL-6 and IL-1 anti-leukin, they may have an advantage earlier in the course. But when we start giving them to people who've already been in cytokine storm and are really down, what we've seen is a huge number of super infections that were often fatal or with multi-drug resistant organisms because they were in an ICU. So again, it's not just whether the drug, when do you need to give it, and then of course what dosage.
So another question that we were asked, and I think it's probably a good one to go ahead and get out, is symptoms. You mentioned it briefly. There's been a lot of talk about symptoms. Can you just, in your experience, give us the primary symptoms that people need to be looking for that are primary indicators of COVID-19?
Sure. So usually it's nasal congestion, dry cough, fever, and then myalgias like you feel like you got the flu or a bad virus. Those are the major ones people present with. And in most people, they're like a not bad flu, and they get through it. The taste and the smell is an interesting phenomena because that means it's gotten to the neurons in your olfactory area of your, and that lead up to the brain. And That's why we're all a little concerned that there appears to be more literature that this disease may not be as benign as we think it is, because it may cause neurological changes which may be long lasting. So we really don't know what that effect is. So when everybody goes, oh, just let everybody get it and then everybody will have herd immunity, that may not be an answer. In addition, so those are the main symptoms. And the other thing we didn't talk about, and actually our head of our anticoagulation team has published a lot on this internationally, there's a huge clotting problem in these patients. Many of them, many of our younger people actually die of clots, not from the pulmonary thing. They get pulmonary emboli, they get strokes. There seems to be a disorder. So actually, on our higher risk patients who don't get hospitalized, some of them we started on anticoagulation as an outpatient, and now all of our patients who get admitted with COVID get anticoagulation, even if they're intubated, because there's a coagulopathy that occurs. But that's not a symptom people would recognize. The symptoms I mentioned are the common ones, and then people may be asymptomatic. Could present with a conjunctivitis, could present with a bunch of little minor things that people may not pay attention to.
Thank you very much, Dr. Jarrett. And with that, I think we're going to have to go ahead and close this out so Dr. Jarrett can make his 1 o'clock appointment. Again, Mark, thanks so much for taking time out.
Thank you. I hope that was helpful for everybody.
Well, given the number of questions and the number of people that observed it, I would have to say that it was. So thank you very much.
You're welcome.
And to everybody
I'm sorry, Steve. You catalog those questions, kind of group them together. I'll be glad if you send them to me to try and get the answers out in the next day or two.
Thank you, Mark. So to everybody who took time out of what I know is a busy schedule during challenging times, thank you for joining us today. Thank you for all of those who passed the word on Twitter, passed the word via social media platforms. We're very grateful for that. And as we've mentioned in passing and in the beginning of today's webinar, the slides and the recording of this presentation will be available for download at www.quanterion.com. Additionally, we had a question about subtitles. Subtitles will be available in these recordings when they're published in the next few days. So again, go to our website, www.quanterion.com, and that'll provide you a link to YouTube to pick up a recording of this video. And to those of you who watch the live stream on YouTube or Facebook, please like the video and subscribe to the YouTube channel so that we can continue to bring you webinars and other valuable content like that. And then finally, thank you for your time today. Best regards to all of you, and stay well.